Hello everyone, welcome to a new session in cardiovascular system pathology. So today we are going to discuss a very important disease of the heart. So most of us would have come across this term myocardial infarction. Before going to the session, let me clarify something. First, this topic is clinically very important. Why? Because a good knowledge about the etiopathogenesis, morphology, consequences of myocardial infarction is very important to know the management which you will learn in medicine. The third most important thing, as far as your exams are concerned, fine. Without knowing myocardial infarction, you can't sit for your second year prop exams. It is such a very important, very commonly asked question in your viva, in your assessments, in your practicals, in your theory, whatever it may be. So, let us have an idea about what we are going to discuss in these videos. I am going to make two videos, number 1 and number 2. In the first video, I am going to give you an idea about what is ischemic heart disease. Because, see, we have lot of terminologies. Okay, number 1 is ischemic heart disease. Ischemic heart disease. Number 2 is angina. Number 3, infarction. So, even though all these terminologies appears to be similar, but they are not so. Fine. So, in this first video, I will be discussing about ischemic heart disease. Number 2, what are the consequences of this IHD? And I will be telling that one of the most common consequences of this ischemic heart disease is myocardial infarction. In myocardial infarction, we have lots and lots of headings. In this video, I will be discussing mainly the etiology, the pathogenesis, then tissue response. Okay, we will be seeing what happens to the myocardium whenever there is ischemia, chronic ischemia. Fine? Yes. So what are the changes? In the second video, we will be discussing what is the morphology. Okay, as far as pathology, okay, from the pathology perspective, morphology is the most important thing that we have to discuss in detail, but I can't skip any of this topics which come between this. So that is why I am going to split this into two videos, not more than like some 20 minutes each. Okay, 20 minutes, total 40 minutes. We will try to cover the whole myocardial infarction. And the second video, I will be giving a fast track revision about what all points you have to finally remember when you sit to write an essay or a long question for myocardial infarction. Okay, what all headings you have to write, what all key points you should not forget. Okay, yes. So with this introduction, let me start with ischemic heart disease. I'm not going to leave even a single point which is mentioned in Robbins, because in 10th edition of Robbins, major updates has been made in myocardial infarction, in its epidemiology, in its etiopathogenesis, in its risk factors, consequences, complications, everything. Fine? Yes. Complications of MI also we will discuss that in the second video. So what is ischemic heart disease? See, normally there will be a demand. Okay? And there will be a supply. Whenever there is an imbalance between the demand and supply, that is supply is perfusion and demand, for oxygenated blood. Yes, whenever there is an imbalance between demand and supply, what happens? Ischemia result. Now, let me clear two important words here. One is ischemia, another one is infarction. Simple, in layman terms, I am explaining. Ischemia, just remember that there is no tissue damage. No tissue damage. In infarction, tissue damage occurs. Simple. This is the difference. What is common between these two? What is common between these two? Both are because of hypoxia. From how hypoxia result? Decreased blood supply. Decreased blood supply. I hope now itself you understand what is the pathogenesis of myocardial infarction. In simple layman term, this is the pathogenesis. Decreased blood supply for long time leading to hypoxia, leading to tissue death, infarction occurs. That is myocardial infarction. Fine? Yes. Okay. So this ischemic heart disease. Okay? Okay. That's what we are going to see. Remember, there are lot of terminologies which, what to say, occurs similar to that of ischemic heart disease. Number one, myocardial infarction. I told you that there will be necrosis. Necrosis means it is an irreversible or reversible. It is an irreversible tissue death. Finish. Angina pectoris. It is nothing else but angina literally means chest pain. Remember, this chest pain is not because of anginal pain is completely different from the MI pain, myocardial infarction pain. Why? Because in angina, the ischemia is not that much severe to cause any infarction. So I am asking you one question. Whether in myocardial infarction, can we describe the pain of myocardial infarction as angina? Absolutely not. Why? Because the chest pain in myocardial infarction is extremely severe. Why? Because the tissue death already occurs. Whereas in angina, tissue death does not occur. And then we have an entity called as sudden cardiac death. So all these terms, overlap one over the other. But I have made very clear what are the difference between these two. Fine. Coming into the reason. Okay, what is the reason? I have told you hypoxia. That is the basic reason. What is the reason for hypoxia? Again, all the risk factor: diabetes, hypertension, atherosclerosis. How comes atherosclerosis? Because of vessel narrowing, thickening. All the same stories is going to get repeated again and again and again. So if you have not watched the video of atherosclerosis, please go and watch the video of atherosclerosis, because if you should know that, first of all, make your mind so clear. You should be pakka clear that atherosclerosis is the major culprit for all diseases. As far as coronary artery disease is concerned, as far as MI is concerned, he is the main culprit. So if you have good idea about how this atherosclerosis happen, how this is going to cause ischemia and infarction, then there is no need of this. Okay, it's very easy. Then learning the pathogenesis of MI is extremely easy. Fine. Okay. Then coming into two important reasons for why the ischemic heart disease incidence has been decreased. Okay, I don't feel that this incidence of ischemic heart disease has been decreased in countries like India. Okay, but as far as US data are suggesting that it is because of control of modifiable risk factors like smoking, good blood cholesterol control, hypertension control, everything, and because of some diagnostic and therapeutic advances like CABG, coronary artery bypass graft, stenting, coronary angioplasty, all those things. Okay, yes. So these are the reasons. These are data are US. We can't apply to a country like India. Fine. Okay. Once this is done, let us see what is the pathogenesis of ischemic heart disease. I am making very clear. I am not going to discuss about what is the pathogenesis of myocardial infarction. I am going to discuss what is the pathogenesis of ischemic heart disease. What is the difference between ischemia and infarction? In ischemia, tissue necrosis or the tissue death does not occur. Fine. That means this injury is a reversible type of injury. So, in a pathology perspective, in pathology terminology, I am going to give you another definition. Ischemia is a reversible injury, infarction is an irreversible injury. Simple, fine, okay. So, what is the two hallmark or the two characteristic steps involved in the pathogenesis of ischemic heart disease? Number 1 and number 2. What is this number 1? It's the chronic vascular obstruction. Chronic vascular occlusion or obstruction. Fine. It has been found that more than 90% of the patients who have ischemic heart disease have atherosclerosis, which involves the coronary arteries. Fine. Yes. So when we will say that, critical stenosis, whenever there is an occlusion of the lumen area more than 70%. For example, I am going to draw. This is the lumen. Consider this is the lumen of the blood vessel. Whenever there is a occlusion, okay, this is the occlusion of around more than 70%. We call it as critical stenosis. Okay, critical stenosis. And in critical stenosis, what will happen? Even a mild, for example, if the patient is just doing a normal mild to moderate exercise, the patient will experience angina. That is called exertional angina. Exertional angina means angina on exertion, on doing exercise, on doing some physical activity which is mild to moderate in nature. Fine. Okay, this is the, just remember that value 70% has been asked in MCQ once. Okay, that is the reason I stressed on that. Okay, yes. Another MCQ. Whenever there is an obstruction of 90%, imagine this almost 90% is occluded, that means the patient may develop angina at rest. So 70% exertional angina, 90% at rest. See, crisp and precise. Don't read what to say. There is no need that you should read everything given in the book. Okay, what all points you should know. You should know that, and at any cost you should not forget these points. Okay, all these are very common questions. You will what if you go for clinical postings in medicine also, they will ask the same questions. Fine, yes, they will ask you go and take Robbins and you read back. They won't say you go and take any day medicine textbooks and read. They will ask you only to go and take back Robbins and start reading again. Fine, yes. So I hope you clear. So what is the first characteristic pathogenesis? That is the chronic vascular occlusion due to atherosclerosis. 70%, 90%. I hope things are very clear for you. Yes. So what happens whenever there is an occlusion? There will be stenosis. What happens after stenosis? Yes, there will be decreased blood supply. Finished. Okay, yes. So what are the blood vessels which are most commonly involved? The most commonly involved blood vessels are called the LAD, that is called as the widow's artery. Fine. Yes, left anterior descending artery followed by left circumflex followed by right coronary artery. Why I say followed by? The most common LAD comes. Okay, I'm going to write it here. LAD, okay, very much common than left circumflex, very much common than right coronary artery. Right coronary artery is least involved. Okay, they may ask you this order in your multiple choice questions. I hope you are very clear for this. Yes. Okay, that is the first. What is the second step? Acute plaque change. What is that? Acute plaque change. So listen, blood vessel. What is it? Blood vessel. What I have drawn in yellow is the atherosclerotic lipid. That is why I draw with yellow color. Fine. This is the starting stage. What happens? The blood will be flowing. Blood will be flowing like this. Blood will be flowing like this. Initially, there will be a laminar flow. But when this obstruction becomes larger and larger, what happens? I am drawing more and more arrows, which indicates turbulence. Basic physiology, basic physics. That's all. Nothing. No more complex things I am explaining. It's very simple. Okay. So this is happening. This is chronic vascular occlusion. What do you mean by plaque change? I have told you in atherosclerosis, there will be smooth muscle recruitment. Fibroblast proliferation, platelet aggregates, all this will happen. So finally what will happen? This atherosclerotic plaque will form a thrombus. It will form a thrombus like this. Fine. I told you what are the fate of atherosclerosis. If you have watched that video, very clearly I have explained what are the fate of atherosclerosis. So here the thrombus will form. This is called as acute plaque change. This plaque may either undergo superficial erosion, it may undergo ulceration, hemorrhage, all these collective changes that this atherosclerotic, I have told you there are stable atherosclerotic plaque, unstable atherosclerotic plaque, everything. I have explained everything in detail. I'm not going to that topic again and again. So the changes that this atherosclerotic plaque is going to undergo, we call it as acute plaque change. What are the changes? Ulceration, fissuring, hemorrhage, superficial erosion, rupture. These are the changes. Okay, rupture, superficial erosion, ulceration, fissuring or deep hemorrhage. All these are collectively called as acute plaque change. Okay, fine. So it is because of this acute plaque change, the patient is going to experience some other features. What are the clinical features the patient may experience because of this? MI, angina, sudden cardiac death. Okay, that is what we call it as consequences of myocardial ischemia. Stable angina, unstable angina, myocardial infarction, sudden cardiac death. How? How this is going to cause all these things? See, stable angina means there is stenosis, because of this plaque there is stenosis, but still there is an increase in myocardial oxygen demand. So even though stenosis is present, the heart is telling, no, I need more and more oxygen, I need more and more oxygen. Fine. And why it is called stable angina? There is no plaque disruption. Very, very important. If you don't mention this word, you are done and dusted. Stable angina, there is no plaque disruption. I hope this terminology is very clear for you. What happens in unstable angina? Unstable angina, there will be thrombosis. There will be acute plaque change. Because of this, there will be some transient reduction in the coronary blood flow. That is why it is called unstable. Why unstable? It is not the angina which is unstable, it is the plaque which is unstable. That is why the angina you experience in such a condition, we call it as unstable angina. Okay, how can the angina be unstable? Fine. Then coming into MI. Whenever there is an thrombotic occlusion. See, MI, we call it as heart attack. Suddenly, okay, spontaneously this is happening. Okay, why? Sudden occlusion. This plaque get ruptured in the form, this thrombus get ruptured, it suddenly go and occlude the left anterior descending artery, the most commonly artery to be involved, infarction. And sudden cardiac death because of in MI there is occlusion. As a result of this occlusion, there will be, my MI, have you heard about any patient who is dying immediately? We say, yeah, it's the first attack. Or we will say, oh no, it's the second attack. We will say like that, no? It's very, unless and until the patient has lots of comorbidities, we very rarely used to hear that, okay, the patient died due to myocardial infarction. Actually, the patient is not dying because of myocardial infarction. The patient is going to die following myocardial infarction. The patient is going to develop a fatal ventricular arrhythmia. And ventricular arrhythmia is a very fatal condition. We can't even before we go and start our intervention, we will lose the patient. So the death is not because of the infarction. The death is because of the fatal ventricular arrhythmia. That is, we call it as sudden cardiac death. So stable, unstable, MI, sudden cardiac death. I hope all these terminology. Why I am taking this much time to explain each of this terminology? Because it's needed. Fine. Okay. Now let us see about angina. So I told you angina, it's nothing else but a pain. It's the chest pain. How I can describe the anginal pain? It's a substernal or a precordial. What is precordium? The area of the chest wall which lies over the heart. Okay, it's a transient chest pain which lasts for some 15 seconds to 15 minutes. The patient will say, yes, the pain got relieved on rest, on lying down. Fine. Whereas that of myocardial infarction pain, the patient will be experiencing a severe constricting band-like pain. The patient will be experiencing some metallic ring is being entangled over my ribs. Okay, it is severe pain. Okay, it's like one of the worst pain the patient have experienced so far in his life. That is how it won't be relieved by rest. Okay, that's very important. But anginal pain, will be relieved by rest. Why? Because it's not the myocardium has not completely undergone infarction or death. Fine. Yes, it is because why this pain? It is because of release of adenosine, bradykinin, okay, and other compounds. We have stable angina, then we have prince-metal or variant angina, and unstable or crescendo angina. Okay, just a few words. Stable angina is the most common form of angina. I told you, whenever there is an imbalance between demand and perfusion. Okay, yes. The stable angina or typical angina will occur when the patient is only doing some physical activity. It won't occur at rest. That is a very, very important point. It will occur when the patient, do some physical activity in emotional excitement or psychological stress. And remember, classically this pain is described as a crushing or a squeezing substernal sensation. It may radiate to the left arm, left jaw, or in some case it is also referred to the right arm also. Okay, and the pain is relieved by rest. Very, very important. Why? In rest there will be decrease decreased demand, so the pain will be relieved. Or by administering vasodilators like nitroglyceride and calcium channel blockers, because calcium channel blockers like verapamil, okay, dihydropyridine, amlodipine, all this has been known to increase the perfusion. So either we have to decrease the demand or we have to increase the perfusion. Both cases the pain will be relieved. Then Prince metal variant angina, it is actually an uncommon form of this angina. Okay, what to say, it also predominantly promptly respond to vasodilators. Why it is called as a variant angina? Variant angina because they are unrelated to the physical activity. They may even occur at rest. This is because of the atherosclerosis, okay, because of the significant coronary atherosclerosis, and at the same time it is unrelated to physical activity. We call it as a Prince metal variant angina. What is unstable or crescendo angina? Crescendo angina, it's a what prolonged, like more than 20 minutes. I told you usually the anginal pain usually lasts from 15 seconds to 15 minutes, 15 to 15, just remember like that. If it occurs more than 20 minutes, like of the severe angina, even at rest the patient is experiencing the typical angina, that is the stable angina, and the Prince metal angina, I told you know, they very rarely occurs at rest. Whereas the unstable angina or the crescental angina, because of the plaque undergo disruption, okay, it undergo disruption, erosion, deep hemorrhage. Because of all these conditions, the patient may experience pain at rest. Just you should know the terminology of this, okay. There is no such what to say, like the morphology or the pathogenesis we are going to discuss in detail. This is the way. What is the reason for that unstable? I told you the unstable, the word is not because of the angina is unstable, but it is the plaque which is unstable. It may lead to fissuration, it may lead to ulceration, it may undergo deep hemorrhage, okay. All those changes may happen. So that is the reason, okay. Then coming into myocardial infarction proper. Yes. So as far as myocardial infarction is concerned, just remember it is myocardial infarction is commonly what we call it as heart attack, okay. Myocardial infarction is what we call it as heart attack, okay. Then coming into the pathogenesis, yes, the same thing. I am not going to explain the same what stories again and again. Just I am going to give you the hint. You are going to arrange it in the form of a flowchart and you are going to present it. Fine. Yes, coronary arterial occlusion, atheromatous plaque, platelet aggregation, coagulation cascade activation, thrombus formation. This thrombus may dislodge. It may form a emboli. It may suddenly go and occlude the coronary artery, leading to infarction. I told you know what is that? 70% critical stenosis and 90% I told you know that is at rest. Fine. Yes. Okay. Yes, and what are the reasons for decreased coronary blood flow? Vasospasm, emboli, okay, and some uncommon causes also. What to see? Emboli in left atrium. It is usually associated with what are the conditions in which embolus? Okay, what are the cardiac causes for an embolus? Okay, this they may ask. Number one is atrial fibrillation, mural thrombus, infective endocarditis. Okay, then paradoxical emboli. What is paradoxical embolus? What is paradoxical embolus? Yes, paradoxical embolism discussed in hemodynamics. That is, the emboli from the venous circulation enters into the systemic circulation. This is because of two reasons. One is because of atrial septal defect, and two is because of patent foramen ovale. These are the two conditions because of which the embolus which is present in the venous system which may enter in. That means from the venous means right heart, into the systemic means left heart. So what are the conditions which communicate between right and left heart? ASD, atrial septal defect, and patent foramen ovale. Then uncommon causes like sickle cell anemia, okay, shock, all those conditions. Fine. Then what is the myocardial response? This is what we are going to discuss, okay. So this is a picture. You can see the depletion of ATP and accumulation of lactate. See, whenever there is an accumulation of lactate, you can see after some 20 minutes, what, okay, or I can see approximately some like 30 minutes, there is an onset of irreversible injury. Fine, okay. That is this table what we are going to discuss. What is the approximate time of onset of key events in ischemic cardiac myocytes? Very, very important. One MCQ must from this table. You can write this table, okay, you can just draw out of this table under the heading myocardial response. Definitely when they ask you myocardial infarction, you are going to write first what is myocardial infarction, next pathogenesis you have to correlate. You can write some points from atherosclerosis, okay. There is no as such pathogenesis like myocardial infarction, because you know myocardial infarction is because of lot of risk factors. There should be atherosclerosis, there should be a ischemia. I told you know myocardial infarction is one of the consequences of ischemic heart disease. So you have to write down the pathogenesis of ischemic heart disease, that is a chronic vascular occlusion followed by acute plaque change. Then you can come to all these factors I have mentioned: platelet aggregation, coagulation cascade activation, okay. Then vasospasm, embolus. What are the causes for all those? You can just present it beautifully in the form of a flowchart. Avoid writing paras, because no one is going to read your paragraphs and stories. Just fix some points. Before you start writing a long question, you should have an idea what all I am going to write within the given time, what all points I am going to present it over. Okay, so write in the form of a flow chart. Then myocardial response you are going to write, very very important, onset of ATP depletion within seconds, loss of contractility less than 2 minutes, ATP is reduced to 50% of normal in 10 minutes and 10% of normal in 40 minutes. Irreversible cell injury occurs between 20 to 40 minutes. Okay, if you give me a single best answer, 30 minutes. And microvascular injury occurs more than 1 hour. This is a very very important table. By heart this value, one MCQ must. Okay. See, this is the progression. This is the progression of myocardial necrosis after an occlusion. See, when the coronary artery is occluded, see how the zone of necrosis you can see. First, there will be a zone of perfusion. This is an area at risk. Then it will undergo mild necrosis. Then this necrosis area gets widened. Okay, this is how this progress. Fine? Yes. So the morphological features of acute MI, it depends upon the location of the obstruction, the size of the vascular bed, the duration of occlusion, the demand of the site of occlusion, then arterial spasm as well as other factors. Okay, these are the various factors, because when I told why we are saying it is a LAD which is most common, because it is the LAD where we have all the risk factors. That is at the LAD only we have decreased the size of vascular bed is extremely high. We have very high oxygen demand. At the LAD territory only, you can go and read back to your anatomy of the blood supply of the heart. Okay, that is in the blood supply. Then you will see the LAD is going to supply almost all the territory of the right heart. Am I right? So the territory supplied by the LAD artery is extremely high. So there is very high oxygen demand, but because of this occlusion, we are not able to meet the demand. Okay, that is the reason LAD artery is involved first. Then coming into the patterns of infarction. What are the patterns of infarction? Yes, number one is what we call it as transmural infarct, and another one is called as non-transmural infarct. Okay, so these are the two important patterns of infarction. These two important patterns of infarction you should write, okay, in the pathogenesis. Okay, just we will see this picture. So this is right ventricle, this is left ventricle, anterior, posterior. Fine. Let us see first transmural infarct. Okay, transmural infarct. In transmural infarct, okay, and non-transmural. What do you mean by transmural? That means endo, epi, peri, all layers of heart involved. Non-transmural means only particular layers is involved. That's the reason. Transmural, in all cases in GIT, transmural inflammation means all layers. So in transmural infarct, it may be either permanent occlusion of LAD, permanent occlusion of left circumflex, permanent occlusion of right coronary artery. I told the order: LAD greater than, circumflex greater than RCA, right coronary. In non-transmural infarct, it is just a transient or a partial obstruction which may lead to subendocardial infarct. Okay, subendocardial infarct or circumferential subendocardial infarct. Okay, this is a regional subendocardial, so only a particular region is involved. This is regional subendocardial infarct. Then what do you mean by circumferential endocardium? Almost the whole of this region is involved. Okay, LV, left ventricle, and small intramural or micro infarct. You can see dot-like infarcts. Okay, just these are the various patterns of infarct. If you draw this picture and if you write this itself, this is more than enough. This is more than enough. So transmural, it may be because of LAD, circumflex, and RCA. In non-transmural, it is because of a regional subendocardial infarct, circumferential subendocardial infarct, or small intramural micro infarcts. Okay, yes, fine. So this subendocardial infarction can occur as a result of plaque disruption. Okay, that is the point you have to remember. It is because of the plaque disruption, and since it occurs because of the plaque disruption, plaque undergo disrupted and it will get dislodged to some other place. That is the reason this in subendocardium why it is called as non-transmural, why it is not involving the whole of the layers. Why? Because when the plaque get dislodged, it will goes to some other place. So the plaque does not get time to invade all the layers. Immediately it will get dislodged to some other places. And multifocal microinfarction, the reason is because of the involvement of small intramural blood vessels. Okay, yes. So these are the important things you have to remember. In subendocardial, it may be the regional, circumferential, or what we call as global. Okay, so these are the various patterns of what we call it as infarction. Okay, yes. And one more thing, LAD, It is going to is a branch of left coronary artery, supply most of the apex of the heart, anterior wall of the left ventricle, anterior 2/3 of the ventricular septum. Okay, all these things. Fine. Whereas the posterior 1/3 of the septum is supplied by the right coronary artery or from a branch from the left circumflex artery. Just remember why LAD is involved. The reason I have told very clear. Okay, so I don't want to repeat it again and again. So that is the reason why, because more blood supply, it is going to supply most of the territories of the heart. Fine. Yes, only few areas of the heart is supplied by the RCA branches. Fine. So mostly it is by the LAD. It has very high oxygen demand. The areas which supplies supplied by the LAD artery is also having very high oxygen demand. So these are the very important points that you have to remember. So in this video, I am going to stop it here. In the next video, we will be discussing about the morphology, that is the gross histopathology, then a few things about the myocardial reperfusion injury, some clinical markers, that is the biochemical markers of myocardial infarction, and the complications. Fine? Yes.